We had an opportunity to talk about some of our cell therapy results, and I think that there are two aspects of where we discussed things today. First, we looked at the clinical data. So we talked about our experience in pediatric ALL, having treated almost 60 patients with relapsed refractory ALL and how that's going. And the data show that 93% of the patients that we've treated have entered a complete remission. So what that says is that the engineered cell therapy that we have tried to treat these patients with, a cell therapy called CTLA-19, which is a CD19-directed chimeric antigen receptor cell therapy, that cell therapy is able to control disease in a large fraction of patients. So the short-term action of these engineered T cells is very strong. The other aspect that we're starting to see now that we've had longer follow-up is that a number of these patients remain in remission. The overall survival is almost 80% at 1 year, and that a number of these patients are able to stay in remission just with the cell therapy without requiring further treatments like transplant. So I think that's, from a clinical standpoint, we see very good short-term disease control and then longer-term disease control in a number of patients that allows them to avoid transplant. The other big aspect of what we talked about here today is toxicity. So these cells are very powerful. They're engineered T cells. They have some of the characteristics of activated T cells. They can produce cytokines, inflammatory proteins, and this results in a cytokine release syndrome. And I think what we've learned about that is, I think, two central points. Patients with a great deal of leukemia in their body, patients who have more than 50% marrow disease, those patients are at very high risk for severe cytokine release syndrome. And patients with lower disease burden, those patients aren't at risk for severe cytokine release syndrome at all. So it's extraordinary that the T cells are able to control even very bulky amounts of disease, but at the price of a higher risk of cytokine release syndrome. Fortunately, we have shown that we can control cytokine release syndrome, and the way that we really have done this is we've realized that one of the more important inflammatory proteins is a specific cytokine that's called interleukin-6. And it turns out that interleukin-6 is not required for T cell activation, so if you block it, it doesn't interfere with the T cells. And it is directly targetable with a specific drug that it was developed actually for patients with rheumatoid arthritis. And that drug is called tocilizumab. And so we can control cytokine release syndrome by blocking IL-6 using tocilizumab. And that really has enabled us to treat these patients with very high disease burden with a good deal of success.